Hello, everybody. This is Dr. Nitin Tandon. I'm Professor and Vice Chairman, Department of Neurosurgery, and Co-Director of the Texas Institute of Restorative Neurotechnologies at the McGovern Medical School at UTHealth, and also Director of the Epilepsy Surgery Program at Memorial Hermann Hospital and Texas Medical Center. All of you have some interest and understanding of epilepsy. Epilepsy is a disease with recurrent unprovoked seizures. These seizures are characterized by uncontrolled and excessive abnormal brain activity. Epilepsy is the second commonest neurological disease after stroke. It afflicts about 1% of all humans, with a lifetime incidence of a seizure in any human of about 3 to 8%. When someone has multiple seizures, repeated seizures that are unprovoked, as in not related to some clear etiology that we can point to that can readily be fixed, we call them as having epilepsy. And about somewhere around 75 million human beings worldwide have epilepsy. In the United States alone, about 3 million Americans have epilepsy. More than a third of these patients with epilepsy are medically refractory in the sense that medications alone are not enough to control their epilepsy. And half of such refractory cases are surgical candidates. So if you do the math, that comes out to somewhere around more than 500,000 to 1 million Americans are candidates for epilepsy surgery, but yet only around 3,000 patients or something in that order undergo epilepsy surgery nationwide every year. I have also on this slide pictures of various poets, painters, and presidents who've all had epilepsy. And I think it's important before we go further to point out that very often patients and loved ones of patients with epilepsy live under a stigma, a belief that this is a disease that should not be discussed or talked about. And nothing could be farther from the truth. I think it's just a chronic disease like any other disease, and accepting that diagnosis and then dealing with it appropriately are really the steps that we should all advocate for. I described earlier that there is a vast underutilization of epilepsy surgery. Here are data from 3 seminal papers that talk about the treatment of refractory epilepsy. On the top left, you can see that once a patient has failed more than 3 medications, the chance of a 4th or subsequent medications controlling their epilepsy is less than 1%. This has been replicated many more times since this paper in 2002. And it's very clear to all of us that when someone has failed 3 medications at good dosages, really nothing more needs to be attempted medically, and that they definitively are candidates for epilepsy surgery. There are also 2 randomized trials that have been conducted for epilepsy. The WEEB study, which was a randomized trial of 80 patients with temporal lobe epilepsy, showed very marked reduction in seizure burden and seizure frequency in those that had surgery versus those that had medical therapy. And the ERSET, or the early surgical therapy for drug-resistant temporal lobe epilepsy by Pete Engel from UCLA, even though the study did not accrue as many patients that they had planned to, showed a very strong, very marked effect of early surgery, creating a major impact on temporal lobe epilepsy. So one might ask why we don't do more of this. We'll get to that in a minute. One other point to make here is that epilepsy surgery is extremely efficacious from a population health standpoint. So you would need to do something like 45 carotid endarterectomies or 25 cardiac bypass operations to have a meaningful impact on 1 disabling stroke or 1 death. You only need to do 2 temporal lobectomies to have a meaningfully improved quality of life. And of course, patients with epilepsy also do die from unexpected causes as well as from accidental causes. But the bigger impact and the more notable impact, and the impact that patients are looking for, is an impact on their quality of life. And it takes very little to get to that point. Further, there's a study here from France on the right-hand side of the slide, which shows that there are uh, cost benefits from societal benefit of epilepsy surgery, and that the direct costs of epilepsy surgery are lower at 10 years as a crossover point, but if patients were only managed medically, they would cost society more in direct medical costs. This is not the cost of a caregiver taking time off from work to take them to a doctor's visit, to take them to the ER. This is just direct medical and hospitalization costs. As we know, this is a chronic illness. There are many reasons for the underutilization of epilepsy surgery. There are issues with how our medical systems are set up, with relationships between primary care providers and neurologists in the community who may or may not have relationships with tertiary epilepsy care programs. There may also be issues within tertiary care programs where the epilepsy neurologists may not be as available to see patients. They may not be trained in managing medically refractory epilepsy or doing epilepsy surgery in some way. And these are all reasons why oftentimes patients do not get the care that they need. Further, there are also patient concerns, and the rest of my presentation today will really focus on this, that patients fear brain surgery. They fear craniotomy where the head is cut open. They also fear this idea of removing something because, rightfully so, they have the opinion that all of their brain is important. And of course, we all recognize that there are parts of the brain that are more important than others, but also that there are parts of the brain that are making seizures which disrupt the functioning of normal brain areas. And the least impact that we can have on normal brain areas as we remove or eliminate the areas that are seizure generating, the better. So with that in mind, I want to talk about how we have been doing surgery in the past and what the change really is about. So for the longest time in North America, more than 6 decades, patients who had epilepsy where there wasn't a clear-cut imaging abnormality underwent placement of subdural grid electrodes. And you can see these electrodes placed here. And every so often, maybe 7 or 8% of the time, there would be bleeding in the head after these subdural electrodes were placed. So this procedure had a certain amount of major complication rate, and also had it was much more morbid because a large craniotomy needed to be performed to place these electrodes in patients' brains. On the other side of the Atlantic, in France, Jean Taylarac, the French neurosurgeon, had from the early 50s and 60s propagated this approach of doing stereoelectroencephalography, a term that he devised in relationship to doing 3-dimensional brain recordings using a stereotactic apparatus that was used to place these probes through little grids in the brain. This approach was never really brought over the Atlantic, and to some extent was used in Canada, but not much in North America, not much in the United States of America. And this was for a variety of reasons. The first being that this approach is very tedious, takes in its original form between 10 to 12 hours, includes an arteriogram, and is very limiting as well. There are only so many areas that can be sampled with probes placed this way. That said, this was and is the beginning of the genesis of the concept that we will talk about in more detail. This is again the illustration that these electrodes are placed orthogonally or from the side of the head only, not from the top and not at any angles to the skull, but really perpendicular from the side, and therefore limiting in many ways of the areas that can be sampled. On the other hand, now we use this approach called neo-stereoelectroencephalography, which is guided both by the imaging as well as by semiology. There is no arteriography or invasive vascular imaging required. And it's not constrained to orthogonal placements. It can be placed, the electrodes can be placed almost in any place. And it's also possible to implant some areas very densely. And all of these uh, advancements in concept combined with advancements in technology, we use a robot to implant electrodes that can be done much faster and with much greater precision than the older French method. So here is an example of us placing a SEEG electrode on a patient. You can see the ROSA stereotactic robot. The robot is programmed to come to particular entry points on the scalp. Here I have marked the entry point and now made a small incision. And we will then take a small drill bit. This drill bit is just about 2 millimeters in diameter and is used to very precisely drill a small hole in the skull that allows us to then place the anchor bolt. So here is drilling through the skull. We'll remove the drill bit. We're now going to coagulate the dura. The dura is a membrane that covers the brain. And once that is done, I'm implanting a small titanium bolt that is cannulated, that allows us to place an electrode through the bolt itself. So the bolt is now in place. We make some measurements to get a sense of how long the electrode itself has to be based on the trajectory and the plan that I have previously made. We will now move the ROSA robotic arm out of the way. And use a small amount of irrigation to clear the bolt. And then I will take a guidance cannula. And now I will take a guidance stylet that makes a trajectory down the path of where the electrode needs to go. You can see a little bit of brain fluid, cerebrospinal fluid that comes out when we do that. And then there is the electrode. You can see how fine it is. It's a 0.8 millimeter diameter electrode, very thin electrode that is then placed, and the anchor bolt cap is tightened. So as you can see, this entire process takes all of about 2 minutes to do. And then we move on to the next electrode that we need to implant. So we've been doing this here at Memorial Hermann and at UTHealth for the better part of 7 years now with excellent results. We very recently published our data in JAMA Neurology, and this is a slide from that work, which shows that the time in the operating room is shorter. The number of electrodes with SEEG, which is shown in this column, are greater. That patient complication rates, including the number of transfusions that they get and the actual complications which necessitate returning to the operating room, are much lower in the SEEG group. And also the procedure is much more comfortable, as you can see here by the amount of morphine. This is milligram morphine equivalents consumed by the patient after each operation. So in summary, SEEG is faster, allows for broader implantation of the brain, is less painful for the patient, and is much safer. It does select the best cases for resection. So when a patient has a craniotomy for placement of grids, it is very unlikely that when the grids are being removed, that the surgeon or the patient will not want to have something more done. The threshold for intervention, as in removal of some part of the brain, is much lower. In SEEG, we have the ability to remove the electrodes and then wait sometimes a week or two to deliberate whether or not the patient is indeed a candidate for epilepsy surgery. And therefore, we select cases most precisely. And in some cases, we might even go back and add electrodes or redo the evaluation, because obviously what is precious is the brain, and we want to minimize the impact on the brain itself from this work. So this has led to this transition at our center where we still do subdural grids, but that number is diminishing and the number of SEEG cases is rising. And here on the right side is the difference in the amount of time that we spend in the operating room. In golden color is the time that it takes for doing SEEG, and in blue, the time that it takes to do subdural grid evaluation. What was surprising to us and what we were not expecting from this analysis is that outcomes were much better with SEEG. So we assumed that the procedure would be safer, it would be faster, would be better tolerated. We didn't quite expect what we found, which is that outcomes, which is patients who were seizure-free, is shown here as Engel class 1 or 2 is seizure-free or markedly better, is 81% for SEEG versus 54% for subdural grids. So that's a very marked difference. And I think it points to the fact that we're sampling a broader network, that we're choosing patients better for epilepsy surgery, and that our complication and our morbidity that impacts epilepsy outcome is also diminished. So we believe that this approach, therefore, is definitively the best way of proceeding with evaluating patients who need intracranial evaluations for epilepsy, and it is much less invasive. This is the same data shown another way, where the class 1 and 2 outcomes with SEEG versus grids are compared here. This is the cases undergoing resectional ablation, and these are all cases that were evaluated. And this is also shown here in different way. This analysis has also been replicated by a colleague of ours at the University of Iowa, who did a meta-analysis. This is not their own data, but they looked at a large number of published papers which also show the same thing, that not only is epilepsy surgery safer with SEEG, that the seizure freedom rate is also greater. I can also show you a little video here to show you that what some epilepsy neurologists have believed for a long time is you have contiguous coverage of the brain with subdural grids, and they don't like the SEEG idea because it doesn't sample as densely. When you explode the surface of the brain, when you blow it up like a balloon, you see just how far these grids are and how much real estate in the brain is not covered with grids. To summarize, this is the old way of doing this on the left, which is subdural grids, and on the right is SEEG. I don't think any prizes for guessing what patients would prefer if there was a real choice in each case, because this is so much less invasive. And this is the end of at the end of the implantation, you see a situation like this. There are still, I think, a few indications for subdural grids where there are superficial lesions that are obvious to us, that need to be delineated, especially in relationship to functional tissue, for the mapping of language or other functions in patients unable to undergo an awake craniotomy, and in very young patients, age less than 3, where the skull is too thick to hold these little anchor bolts that are used for SEEG. So with this, we have now identified which part of the brain is responsible for the epilepsy. So now, wouldn't it be nice to be able to combine this minimally invasive way of localizing where seizures start with a minimally invasive way of destroying the seizure focus? And we call this technique laser ablation of seizure focus, or LITT, or LIT. So combining SEEG and LIT allows us then to do epilepsy surgery with as little impact on the brain. So I'm going to talk for the rest of this webinar about LIT. So stereotactic laser interstitial thermal therapy includes placement of a laser cannula that is implanted stereotactically into the brain. And then the procedure is really performed after that in the MRI scanner, where we monitor tissue heating and estimate precisely the amount of damage in the brain using a mathematical equation to determine how much tissue has been destroyed by the amount of time and the amount of intensity of laser energy that that tissue has been exposed to. This is us placing the probe. This is using a stereotactic frame. We also do this using our stereotactic robot. Once the probe is in place, then we proceed to ablation. What LIT does is it increases the therapeutic window, it minimizes neurological and cognitive risks, it minimizes damage associated with the approach, it maximizes the damage to the target, it decreases the uh, uh, morbidity associated with the surgery, both in terms of pain and suffering and length of stay. And I think getting back to the point earlier about the underutilization of epilepsy surgery, it increases the accessibility of epilepsy surgery for patients unwilling to undergo open surgery. And for even for patients willing to undergo open surgery, it offers in many cases a potentially less complicated option, albeit in some cases with a possibly lower seizure-free rate in those patients in whom open surgery is an option. So what are the types of epilepsy that we target with LIT? So the commonest is mesial temporal lobe epilepsy. This is hippocampal epilepsy, for which we have traditionally had an open craniotomy to eliminate the seizure focus. Hypothalamic hamartomas, periventricular nodular heterotopias, focal cortical dysplasias, and cavernous malformations. And we have targeted all of these types of epilepsy here at UT and Memorial Hermann using laser ablation. I'm going to talk first about temporal lobe epilepsy. This is the hippocampus removed from the temporal lobe. It's called a hippocampus because, as you can see here, it looks like a seahorse. And the seahorse, the Latin word for seahorse is hippocampus. And so that's where the word comes from. It's a structure that is important for memory, and it's a learning structure in the brain. But once it starts to make seizures, that process takes over its function. And like any other learning machine, it learns how to make seizures more and more efficiently and vigorously in most cases, leading to a situation where the seizure burden increases in the patient and leads to a marked impact on their daily life. This is the hippocampus now seen on an MRI scan. This is a view that is perpendicular. So this is the shape of the hippocampus, but the slices of the MRI scan are not made in this plane. They're made in these lines that are dotted along the head and the body of the hippocampus. And you can see that there are various subregions in the brain, and these subregions are what we localize the damage to in various types of epilepsy. We've known for a long time, this is the work of one of the founders of epilepsy surgery, Wilder Penfield, that the hippocampus is crucial for controlling temporal lobe epilepsy. He did recordings from the hippocampus, and this is just a historical vignette to show how far back our knowledge about the role of the hippocampus goes. People have tried to do various less invasive but open operations to target the hippocampus selectively. And here's a meta-analysis or a combined analysis of many, many papers doing this approach, all of which showed that the less invasive approaches didn't necessarily, the open surgical approaches didn't necessarily lead to the amount of cognitive improvement that one would like. Further, it's also important to point out that one of our major goals in epilepsy surgery is to minimize those patients in whom we don't result in a marked improvement in seizure burden, yet lead to a cognitive deficit. So the worst kind of outcome in epilepsy surgery would be if we were to do surgery and not make this epilepsy go away, but give the patient a cognitive or memory or other such deficit. And so it's really important for us to keep that in mind as epilepsy surgeons, and we take this very seriously. To minimize that potential, we, in many cases, will advocate for minimally invasive, for more minimally invasive options than open surgery. I'd like to go now to a few illustrative examples. So this is a 33-year-old NASA engineer. He was 33 years old when he came to see us. His seizures started when he was 3 years old. These were initially febrile seizures that were controlled on medications. But then his seizures recurred at the age of 21. And when he came to see me many years ago, he had a left temporal epilepsy. He refused surgery at that time due to concerns about memory decline and dysnomia, and we placed a vagus nerve stimulator. The seizures became smaller but continued. And he got married. He had a son, and he realized his wife would not leave him alone with his child because she was concerned that he might have a seizure. His VNS battery died, and he came back to us, and he was interested in laser ablation at that point. So this is him. This is the laser applicator placed in his mesial temporal lobe. This is a damage model produced in the mesial temporal lobe by us. This is produced in the MRI scan, and these images are from real-time ablation in the machine. And then this is an amalgamation of all of those images to create a net damage estimate. And as you can see, what we do is very, very precisely target just the hippocampus. Nothing around this is damaged. It's just the structure that's making the epilepsy. This is in this orange color here. And it's a very precise, very complete ablation of these mesial structures. This is amplified here. And then at the end of the ablation, we give the patient a small dose of contrast agent with an injection, and an intravenous injection of to outline the boundaries of the ablation. So this is him. This is him about 5 years after surgery. As you can see, his IQ, if anything, got slightly better, did not diminish. And he still works at NASA and works on discharging plasma from the International Space Station, doing great. Has no perceptible changes in his performance at all. So for hippocampal sclerosis, we've done at this point somewhere around 70 or 80 patients. We've done more than 100 total laser ablation cases, but we wrote up our first 43 cases in whom we had at least 2 years outcome data. And as you can see, that the survivor analysis shows that 76% of our patients are seizure-free at 18 months. So that's a very high number. It's higher than most of the other series that have been published about epilepsy surgery using laser ablation for temporal lobe epilepsy in the past. I think it speaks both to careful selection as well as careful technique applied to this population. This is just a planning method to optimize the targeting of the hippocampus. You can see the shape of the hippocampus here extracted from the brain to make this model for ablation. And our experience now gives us insight into designing really optimal trajectories for ablation. And as you can see here, in general, about 70 to 80% of the amygdala and hippocampus are eliminated this way, which are the structures that we are interested in. About 28% of the entorhinal cortex, which is part of the temporal lobe just adjacent to the hippocampus. And beyond these structures, nothing else is ablated at all. Now, this procedure is also very safe. Patients leave the hospital the next day. It's very well tolerated. There's minimal pain, minimal discomfort. A very small patch of hair is shaved in the back of the head. And so it's really something that people appreciate receiving as opposed to a traditional open operation. And the outcomes from this approach are much better in terms of naming outcomes, or the impact on language in the dominant hemisphere is much less. And there's also possibly a lesser impact on memory, although we're still quantifying that with a larger group of patients. In the non-dominant hemisphere, we think that there may be a possibility of better object recognition, although that doesn't seem to be as much of an impact in the non-dominant hemisphere. That part of the brain is not as important or as crucial as the dominant hemisphere. But certainly in the language dominant hemisphere, which in most people, it's the left temporal lobe, if there is a choice of a laser ablation, we prefer to do that because it leads to a lower impact on language function. Another consequence of temporal lobectomy can be an impact on visual function because the visual pathways, which are shown here in the tan colors, are very close to the hippocampus and the anterior-most part of these radiations as they travel from the eye back to the occipital lobe. Temporal lobectomy has a approximately 30 to 40% chance of causing some deterioration in visual function. Another advantage of laser ablation is that this impact on visual function is much smaller. It's almost non-existent in the right hemisphere, and in the left hemisphere, it is much smaller. The area affected is much smaller than with the traditional operation. This work is in review and should be out soon, and it will validate the fact that this approach is minimally invasive on visual function as well. So here are some of my other patients. Christine Melody, wonderful young woman whose epilepsy had led her to have seizures 20 to 30 times a day, was unable to function, unable to really function in school, and had laser ablation, is doing really wonderfully at this point. Jennifer, who is a cardiology cath lab technician, same problem, unable to function normally at work. And both of them had dominant temporal lobe laser ablations and have done spectacularly as a consequence of this approach. William is on the right-hand side. This is one of the co-inventors, Ashok Gowda, of this technique, where we were meeting at a conference about this approach and about the efficacy and its success rate. I'm going to move to another case now. This is a 32-year-old right-handed lady with seizures that started at the age of 22. And these seizures led to a sense of visual distortion, of things spinning, and then to a complex partial seizure where she lost awareness of what was going on, a classic temporal lobe seizure. And she had a scalp recordings that showed right posterior temporal spikes, right temporal onset, and then a abnormality in the posterior temporal and temporal occipital region, which I will show you in a minute, which is very high functioning, very bright lady. So this is her EEG showing a right temporal interictal discharge pattern and then a seizure onset in the right temporal lobe, which corroborates the idea that she has a right-sided problem. And then here is her abnormality, and you can see that she has this problem called periventricular nodular heterotopia, this collection of abnormal brain cells that lives next to the ventricle and is trapped there during development and does not migrate out to the to its normal location. Over the last 6 years now, we have seen more than a dozen such cases, and we're becoming a center for PVNH to elaborate its molecular as well as genetic and clinical manifestations. This disease is commoner in women and is often bilateral and can lead to devastating epilepsy. And given that the abnormality is deep inside the brain, there has not been a safe and efficacious strategy for managing this up until now. So this is her. She underwent SEEG. As you can see, this is what the SEEG probes look like on the outside of the head, and here she is smiling at us. And these are the areas in the periventricular nodules where the onsets were. We used this information then to come up with a strategy for her. She's a graphics designer, she's an artist, and at that point, she wanted to have children, she wanted to drive, she did not want to be disabled by a visual field deficit. So for a traditional operation to work here, we would have to cut through the brain to get to this deeper portion, and that cutting through the brain would lead to a loss of visual function in the left side of the body. So a right-sided resection here would lead to a left-sided visual field deficit. And this, this problem, this fact, precluded her from being interested in undergoing this open procedure, but she was very interested in minimally invasive approaches, as will we. And so what we did was apply 2 separate laser applicators to target this polymicrogyria and the periventricular nodular heterotopia separately. And then this is her getting her ablation. Again, you can see these areas of ablation turn on in the scanner, and we can move the fibers in different ways to get all of the tissue that we're interested in ablating. And then here is the MRI scan obtained right after ablation. As you can see, all of that abnormal tissue has been destroyed, but all the tissue above it, all the normal occipital lobe and temporal lobe have been preserved. So this was done at this point about 4 years ago. It led to a very small visual reduction. So she did lose some vision, but this is not enough to preclude her from functioning in most ways in normal fashion. So we were able to accomplish destruction of the tissue, preservation of most of her visual function. And this is her now with her baby, who's just about a year old. She came back to visit and it's really done great and very happy, and we're very proud of her. This is the kind of amalgamation of a minimally invasive localization combined with minimally invasive ablation that a patient like Alicia had, which allows us to feel really comfortable in recommending such approaches for many more patients in the future. Patients who have deep-seated lesions, patients in whom preserving function is of paramount importance, and of course, those who are just scared to have a craniotomy, a traditional approach to their epilepsy. We've published some of this work as well, and more is on the way. And we've shown success in ablation and success in outcomes. One other entity that we have seen a lot of and we're very interested in dealing with is cavernous malformation. So this is a 32-year-old who presented with two problems: a tumor, a large tumor, as well as a cavernous malformation. But really, her major problem was epilepsy or seizures. Given this large brain tumor, we didn't feel it wise to do two separate craniotomies to remove this abnormality and to remove this subsequently. And so we targeted this with laser therapy. And here is the ablation showing that that entire abnormality is gone. And she has now been seizure-free for more than 2 years with no impact on visual function. So this is a third type of disease, so mesial temporal sclerosis, periventricular nodule heterotopia, and now cavernous malformations. These are the commonest of the abnormalities that we target with this combined SEEG and laser ablation strategy. Many cavernous malformations don't need SEEG because we generally know where the seizures are coming from in this population. I'd like to thank all of my neurology colleagues on both the adult and the pediatric side, and these are Dr. Latu, Dr. Hope, Thomas, Thompson, Gowda, our neurologist, Dr. Friedman, our epilepsy nurse coordinator, Ms. Jessica Johnson, the pediatric neurologist, Dr. Von Allman, Langford, and Watkins, my pediatric neurosurgical colleague, Dr. Shaw, our MEG director, Michael Funke, and our neuropsychologist, Dr. Breyer. Without all of their help and collaboration in this, none of this work would be possible. Thank you.